I'm actually going to check it on my phone because I never know if I don't have another person on here to help me figure it out.
It's showing that we're streaming live.
Okay, awesome. Hi, everybody. This is Lori Jean from United States for Medical Freedom, and I'm here with Sara NP and Lauren Kirckof, and we just wanted to do a follow-up for you guys on COVID. So we have found some new information. This is a follow-up to a previous live that we did 3 weeks ago, where some nurse friends and I talked through Dr. Cameron Kyle Seidel's theories. He's on Twitter. He's been kind of sounding the alarm of the necessity for us to pay attention to what we might be doing with ventilators, how we might be hurting patients instead of helping them. And so he has continued to sound this alarm, and some doctors and nurses have attached to that theory. And that theory also comes from Dr. Gattinini, and he is from Germany. And he is the godfather of ventilation. He is the one who created or invented baby lung. So this is really going to be for all of your family and friends to get a follow-up from that. And if you'd like to watch that as a precursor, we did have it tagged at the top of the group. It'll be underneath the See All button, and you can click on that because it was an announcement. So if you want to check that one, but here is the follow-up. We're also going to cover some inside information from some friends of ours who are nurses in New York. So we have some really important information for people to know and pay attention to about some of the things that are going on across the country, but especially what's going on in New York, because a lot of people want to know what's so different about this disease in New York. What's going on in New York? So we just wanted to start out with that. And I think that we could start out just by, and this is, by the way, information that we received from the front lines, people that are not able to speak out. And so we're their voice. We're the ones speaking out for them. And we are a lot of nurses that are trying to speak out and to help protect people. We're not going to name hospitals. We're not going to name people, but we will say that we have seen a trend in these types of things going on at lower income hospitals and locations. So it may not be across the board. Of course, it probably isn't. Like, all of New York is not necessarily this way. And just so you know, we're all nurses. We love our patients and we love fellow nurses. But obviously there's a problem with some things that are going on, and we just want to be able to sound the alarm to help them. So I know that we have, let's see, let's talk about upper respiratory infection. So someone comes into a hospital and they have an upper respiratory infection. Like, typically they're short of breath, they're kind of having a little trouble, right? They just like show up, and but these people are talking in full sentences, they're alert and oriented ×4, you know, they're able to speak to you. And in New York, what's happening is they are being put on what's called a nasal cannula, where you stick some oxygen on. And if they're not able to hold 6 liters, like if their saturations and oxygen levels are not able to hold above 90 or 92%, then they're ventilating them. And 90 or 92% is not our typical ventilation stage. So it's rare we would ever intubate a patient that is holding 90% sats. And so we're just trying to sound the alarm that that's already something that you don't just jump from like a 6 liters of nasal cannula to intubation. Like, there's other things that we can do in between. So let's talk about what could we do in between these things.
Absolutely.
Ready to go.
Are you passing the torch?
Yes, I'm passing the torch. Let's talk about what we could do instead of just nasal cannula to intubation. What could we do instead?
Right. So I'll start and fill in a little bit for anyone tuning in. You know, I understand, you know, that there are fear, like, nobody wants to be sick. You know, you have plans, like, you don't want to get sick. You, in general, don't want to get sick. With that being said, this illness is not something that is deadly or that should be deadly. This should be like any other illness: flu, cold, respiratory illness, pneumonia, to where, most people would fare through it fine, but there will be the occasional person that needs a little bit additional support, and things that anybody could be doing daily to take care of their health and to keep from getting sick outside of the normal, like wash your hands, stay away from people that are sick, are high dose vitamin C. You can take it orally. The thing with vitamin C is that when you take it in high doses, it can cause GI upset. So it can cause diarrhea, it can cause nausea. It's not a bad thing. It's just that some people can only tolerate so much, or given, in smaller doses over a period of time. So that's why they have IV vitamin C. You can give high dose IV vitamin C. And it's something, honestly, that I wish across the board, not just in the United States, but globally, that if patients come into the hospital and they're exhibiting signs and symptoms of respiratory illness, automatic, as long as they can handle fluid, that they are given high dose vitamin C daily as they are admitted into the hospital. And I feel like, we'd see a lot better outcomes. So that's one of the things that can be done. Again, I want to reiterate, this is not something that, number one, people should be hospitalized for, but there is going to be the person that needs a little help to get over the hump. And that's, in that case, they would go into the hospital. And some of the things that we want to talk about here is how important, number one, it is to have an advocate. Even if you're, like if you have a loved one that's going into the hospital, that you absolutely, there are things that you can put into place. And there is also, you can fight for your right to be there with your loved one and to make sure that they aren't going straight to intubation. Again, something that is unnecessary and often harmful in this situation. So this is not something that should be deadly. This is something that we can stay healthy at home with taking, whether you're going out or at home, taking high dose IV vitamin C. And in the hospital, it's something that has been very successful in treating patients that needed to get over that hump. They needed more oxygen and they needed, high dose IV vitamin C. So I feel like I'm rambling. I'll let you chime in.
I think because of all the panic that's been created by the pandemic, that's part of why people aren't allowed in the hospital to be with their loved ones. On a good day, you should have somebody with you.
Absolutely.
To advocate, so throw in the pandemic, and they're being stretched thin. Staff are being stretched thin. They're exhausted. Sorry.
No, it's okay.
That's okay.
We're all mamas.
Yeah.
So instead of just nasal cannula to intubation, what can we do?
Okay. So you've got high flow, right? You've got non-rebreather masks. The biggest thing that's not being utilized that really would be a great idea is CPAP and BiPAP. Unfortunately, there was this belief that using CPAP and BiPAP, because those are not closed systems, that would spread the virus. And that's something that I think we've been discussing for a few weeks. But Lori, I believe you have an article that discusses that, the concern for aerosolization of the virus, and that perhaps the less invasive ventilation would be a good avenue to pursue for a lot of these patients. The concern, of course, from the beginning for us has been that, or at least when we stumbled upon Dr. Seidel's work, is that intubation is causing more harm than good. And it's a really difficult when staff, the frontline people are in the midst of this and they're being stretched thin and they're running on E, to take a step back and look at what they're doing and even acknowledge that maybe what we're doing is causing harm, until Dr. Seidel sort of raised that flag, that warning, that concern.
So
it's also an issue that, go ahead. This article is important. Of course, it states clearly here that it's not been peer reviewed, and this is like hot off the press. It was posted April 20th, 2020. So it does need to go through further review. And thank you for highlighting the abstract there. There was no variation in aerosol level within patients between room air, 6 liters, nasal cannula, 15 liters, non-rebreather, 30 liters, humidified high flow nasal cannula, and 60 liters, regardless of coughing. So that should, if this turns out that this is true, that would hopefully alleviate some fears, in that these methods could be used to help oxygenation and help patients keep higher oxygen levels. We monitor O2 sat, and that's what, from what we're told, is dropping scary low in these patients. But yet some of them can still walk and talk, and they're even signing consents to be intubated. As Dr. Seidel was saying, it's unusual that you intubate somebody that's like sitting there still talking to you, and yet they're signing consent to be sedated and placed on a ventilator, because it's sort of what we know. Those are like the clinical practice guidelines right now. This being a novel virus, that's just what's being done. It's what we do. And of course, in healthcare, there's always a danger in just doing something because it's what we do. It's what we've been told to do, so we do it. Because that indicates then that maybe there's not critical thinking going on. Nobody's thinking outside of the box. That's what Dr. Seidel was doing when he posted his videos.
Yeah, so this right here to me shows that we're really only utilizing this very first one. So we're up to 6 liters, but then we could do up to 15 liters. We could do up to, with non-rebreather. We could do up to 30 liters with high flow, and then even up to 60 liters per minute, regardless of coughing. So it's not aerosolizing. They're saying in this abstract, they're saying that it's even regardless of the patient coughing, that it's not aerosolizing. Which, how important is this information if they're not running codes? Because compressions are going to push out the virus. The fear is that the compressions of coding will push out the virus, and therefore, if they code, we're just not going to respond.
Right. That was something that was shared. And that's really awful. It's so concerning to think that possibly there are people who have died who could have been saved with different measures, and they just weren't being utilized. You know, if those people who ended up suffering more because they were inappropriately being intubated when that wasn't the best move for them, there could have been less invasive measures in place. Or, you know, I mean, something like compressions, that's, you know, part of learning a code. So it's very concerning to think that those measures aren't being implemented. And going forward, you know, again, this is a novel virus, so people are flying blind out there, just doing the best they can with the information they have. But you've got to be questioning that. I think that's one of the biggest take homes here with COVID is, especially for people at the bedside, you know, just carrying out orders because it's just what we do and it's just coming from the top down, to question sometimes what you're doing. Why? Is it what's most effective? What kind of results are we getting? There seems to be a very great disparity among patients with the virus, right? We hear of the people who are fine, they have totally mild symptoms, and those who become really severely ill. So there's a disparity in clinical outcomes, and there's a disparity in different parts of the country where, you know, certain cities are being hit really hard. And of course, you know, some of that is just due to density in the population. But you got to ask those hard questions, like, why is there such a disparity? What's being done in those parts that isn't being done in others, or vice versa? What is being done in some parts that isn't being done in those other places? And so we've seen from other nurses out there who are speaking up that they are avoiding the ventilator if they can. So, you know, in some places they're avoiding the ventilator for as long as they can, and not intubating patients for as long as they can. And then in some places they're just going right to that after just nasal cannula.
Right.
Definitely. And that's something I forgot to say, of course, because, you know, we've been talking for a while now, but our friends did tell us that they're running codes and no one's coming. So it's like they're telling people, hey, code blue, but nobody comes. So that's terrifying. I mean, if that was my loved one, I would want them to do everything they could, unless they were DNR. Like, we all know that if somebody is DNR, that you don't do that. Mm-hmm. But unless they're a planned DNR and they have signed that consent and they have given that, you know, information to us, then we don't just not respond. That's just not in our nature. That's not something we do. So the fact that that's just kind of what's being done across the board out of fear is really problematic.
Right. Out of making those decisions out of fear. And even again, going back to just having an advocate at the bedside, making that decision, if that's fear driven, that we're going to spread the virus, if there's another person here, that person can get the virus. And then now we have another life to worry about. They've contracted the virus, but how do you balance that with the compassion of having somebody there, just to even have a set of eyes on what's going on? And look, I hate to say it, but I wouldn't be surprised if, on the inside, part of the concern there is there's probably a lot going on right now. We're not under normal circumstances. This is like emergency. They're being drained in some places of resources, whether or not they should be, if those resources are available and they're just not being properly utilized or in the right places. If the hospital systems don't want to be watched, the hospital systems don't want a family or visitor there because they don't want firsthand witnesses to say,
accountability.
I watched, is accountability. Exactly. Now, I don't know if that's the case, but again, a hard question to ask. I mean, is that feasible that patients can have one designated person to stay with them?
I think that's
not visitors in and out, but somebody to be their advocate.
Absolutely.
Yeah.
And I think it breaks the nurses' hearts too. I've heard that the nurses, it just breaks their hearts that the patients are alone and they try. I mean, these nurses are being pulled in so many different directions and they want to be able to be that support person for their patient, but they've got other patients too that are critical.
Yeah. And in our last conversation, I mean, I was talking to nurses who are, they're the last, they're the last person the person sees. They're singing to them as they're dying. They're, they're trying to be there. It's so heartbreaking. I mean, I heard from one nurse that she lost 3 patients on that shift. And I was just like, oh my gosh, that's terrible. So what could we be doing different, I guess, is the question. And so we could be going from 6 liters all the way through BiPAP, CPAP, high flow, and some places said they even did both. Like they did a nasal cannula and they did a mask on top. So it's almost like oh, sorry, go ahead.
We do that on a good day, with some patients, especially in telemetry, and it's helpful. So, it makes sense. Really quick before you go on to the next point, I want to point out again for the stories you hear, nurses that have lost multiple patients. Again, it's not something that should be occurring with this virus. So what is wrong? Without placing blame on that one person, it's an entire team. And, Sara has put it very gently, that there's a lack of critical thinking that needs to take place. There needs to be an advocate and something's missing here.
And the management of resources too, because some places are doing great. Some places have this down.
Right. Exactly.
Yeah. And the question is, I mean, why so many deaths in one location? I mean, of course, like New York is all on top of each other. There's so much density. Like, of course, that plays a role into things, obviously. But I mean, some of the ways that we're treating things, and maybe we learned some from them, what not to do because these things came out. I don't know. And let's hope so. I mean, let's hope. But there was
nothing else. We learned something from all of this and all these deaths, right? That we learned to do better.
Yeah. Absolutely. So they're giving, they're asking for consent from people who are walking, talking, they're just having a little bit of respiratory issues and they're signing consents because they're scared. This is fearful, they're scared. They're like, okay, I could tank any minute, right? So they're signing consents for ventilation. They're chemically restrained, which is just given a paralytic and a sedative or whatever, so that they're paralyzed, because when you're ventilated and you're walking, talking person, you're going to fight that ventilator, right? So it's not like normal to have a tube down your throat and something else breathing for you that's abnormal. And so you want to fight it naturally. So they're given these chemical restraints and sedatives and everything. And then they're given broad spectrum IV antibiotics is what we're seeing on the floor. So I'm not saying all hospitals are only doing these measures, because I have heard of some places doing hydrochloroquine or IVC, but for the most part, what we've been hearing is they're not doing those measures. They're not using hydrochloroquine or chloroquine. They're not using Z-Paks. They're not using zinc. They're not using high dose vitamin IVC. So they're not using a lot of the measures that we've been told are working and helping people.
And again, this is where when I talk about that disparity, because there are some places who are utilizing that.
Yes. Yeah, and I found out
it's just, isn't it odd that there's such a disparity, and then that there's the numbers to show for it?
Yeah, and I do know a nurse in New York who is doing that at their hospital. So it's
Right.
not all hospitals in New York that aren't doing it, but it's like one that I've heard of so far versus several others that are not. So it's like I'm not sure why these ones are doing something and these ones aren't. And I'd love to see the numbers, right? Like who's actually leaving this hospital better, not being 80% ventilated and dying versus like, I mean, I'm sure the numbers are different. I'm sure they are. I haven't seen those obviously hospital to hospital, but somebody can get those numbers and we sure should find that out. The next thing I was going to say is there's a charge nurse who said a fever of 104, no meds were given because he's dying. So they're not giving medications to patients who need them when their fever is 104 because they're just dying. So, I mean, is that acceptable?
No.
So this is where the triage situation defense comes in, I guess, you know, where people will say, well, look, this is a triage situation. There's so much going on. If you know somebody's not going to make it, they're tanking. What do? Do you move on and treat the next patient, right? That's what you would do in triage if you know that that person is not going to make it. Again, who's making that decision? Because there's nobody there to advocate for the patient. If resources are really spread that thin, do you have a whole team of nurses making the best decision for that patient, or are they just there because there's no accountability? Are they making rush decisions,
right,
to move on to other patients?
Well, and what we heard was there's 300 plus nurses sitting at the hotels that are paid by FEMA that are literally available, and yet they're not in hospitals with the normal nurses who work there all the time. I mean, they might get a couple in there to help them out, but like they're still the tired nurses. They're not fully leaving.
They should be on the floors.
Exactly. So you have people waiting in the wings to help, right? So why aren't they being utilized? Again, utilization of resources, management of those resources. If they're being paid to be there, people are going there to help, and they're not being utilized to like the full capacity that apparently it's needed. If nurses are saying that we're swamped, the ratios are unsafe, I mean, how could that be when we're flying in nurses from all over the country, and then in other places you have hospitals that are so slow, they're sending people home. It just doesn't make sense. And that's where those hard questions come in. It doesn't make sense. It doesn't add up. So how are you understaffed and
there should be
one-to-ones?
There should be one-to-ones in those hospitals, and maybe even additional code teams set up to help in this scenario. But I want to zero in on some of the points that you're bringing up, Lori, that we've heard firsthand. It's not just New York. It's not, specifically all of New York. It's certain hospitals in New York and across the country. I believe there's varying degrees or grades of what's going on that are all encompassing with what I'm about to say, is that, these hospitals that we're referring to, that there is a level of negligence that's taking place, and that it is concerning. For example, that patient that wasn't treated and was deemed, that they were going to die, is something that was easily treatable in, a normal scenario, and why that's, being allowed to take place. And I don't know if you want to touch on, the CDC coming out with a criteria in which they can, and Sarah, maybe you could touch on this too. The CDC and their criteria, their broad range criteria in which they can label COVID deaths and hospitals getting reimbursed. So is there something, nefarious going on to which these hospitals are, in lower income areas, they're not receiving as much money, and that they are looking at ways to quote unquote survive, or to fill their quotas, or to make money? I mean, you have to you're putting it gently, you have to ask those hard questions. Like, what is going on here?
Mm-hmm.
Why are there so many COVID deaths? Again, you could look at this so many different ways. It just shouldn't happen. You have nurses that are
Mm-hmm.
there as backup. You have doctors that are there as backup. It's not making sense.
Mm-hmm. It certainly does make you wonder. And look, we've had people from the inside say those types of things, that whenever there's a monetary incentive to do something like that. Look, hospitals need to be reimbursed. They need to receive funding to provide the proper care. But unfortunately, when money becomes an incentive, that is a slippery slope. And regarding the negligence, again, the whole panic surrounding COVID-19, it's like the standard of care that would normally be given when we're not dealing with a pandemic scenario is very different than what's actually occurring. And it's happening under that umbrella of, some of the rules go out the window because this is not normal what we're dealing with. So, just do the best that you can. Well, guess what? The best that you can is going to be really different depending on who's your nurse.
Yeah, absolutely.
So that's real concerning when you don't have an actual standard, or you don't have critical thinkers. You don't have, Dr. Siddell is not your doctor. And, even he couldn't implement the care that he wanted to. He couldn't try some of his ideas. If patients are going to die, if that's what was happening for his patients, and he wanted to try something different, if you have a family that says, hey, look, we've got nothing to lose if my loved one is going to die, let's go for it. Let's try something else. And he was pulled from that position.
Right.
Because people can't just start implementing their own protocols. So we're dealing with that mindset of understanding standard of care, what's actually happening right now. And it's happening because of the panic surrounding COVID. Even for the nurses are fearful. People are scared. And it's that fear that's my concern, is leading to maybe not the best decisions.
Right.
Yeah. They get paid $13,000 for a COVID tested positive versus $39,000 for a ventilated patient. And, our inside information has told us that almost every single patient is ventilated. I mean, that's extremely rare. And it's not even just, whole floors have become ICU floors now. Sometimes it's downstairs as well. Sometimes it's the whole hospital. They're saying that a lot of these rooms are being put, as almost like COVID hospitals, and they're all ventilated or almost every single patient. That's that's crazy. Right. So it definitely makes you wonder, like, you get $13,000, or if you ventilate them, you get $39,000. We already know that the numbers are bloated. We already know that they've been saying that it was like a COVID death because it was with COVID, not necessarily caused by COVID. So we know that a lot of times, even Candace Owens and people have called people out saying like, well, you said this baby died, from COVID, when really it was asphyxiation, so different, which is terrible. I'm not, I'm just saying it wasn't a COVID that killed that baby. But of course, every mother and pregnant woman on the planet now is like, oh my gosh, my baby's going to die of COVID. So we have to be very careful. And there's a lot of other bloated numbers as well, just because they had a heart attack, but they died of the heart attack, but because they were COVID positive, it's not even what killed them, but they'll say, oh, they died from COVID. You're like, oh my goodness. So now we have a decline in all of influenza, a decline in all heart attacks and all kinds of stuff that everyone else was dying of. It's just all dropped off the planet, and everyone's dying of COVID now.
And that's what we were talking about before. Again, working in telemetry, I've worked in CCU, step down. All of those units are very similar, and you get a consistent amount of admissions throughout the year. It doesn't change. It's not like we go weeks to where it's like, oh, we're really having some slow weeks. You might get lucky on a shift where it's not so crazy. However, during this, like we've talked about, nurses and staff members have been furloughed because hospital census is so low, and these hospitals have to stay afloat. Some hospitals are at risk of shutting down because they're not making money. And so you have to question, well, and the number of COVID cases has risen. So where have these patients gone? They've been reallocated. you can only presume that they've been reallocated. These regular patients have been reallocated as COVID deaths or COVID patients. And if the patient hasn't been tested, correct me if I'm wrong, but if the patient hasn't been tested and they die of COVID-like symptoms, or they let's say they have an MI, but they had COVID-like symptoms and they didn't actually test them, they can label that patient as a COVID patient as well. So that's
it's called rounding the numbers or something. Or what is it called? Where they can just I forgot the term. I just saw it yesterday. I'm sorry, but yeah, they can.
Absolutely. So that we can talk about.
Well, and onto that, they don't have rapid testing, so they're waiting. So in certain hospitals that we've heard of so far, they're waiting up to 5 days. So they're not doing the 15-minute rapid test. They're not doing anything like that. They're waiting for the 5 full days. So a lot happens in 5 days in critical care, you guys, right?
Right.
So I mean, that's crazy. So yeah, they're waiting the full 5 days. You know, these people are getting laughed at when they're mentioning some of these other treatments, or can we get faster testing? It's crazy. I don't know what you were going to say next, though. What were you going to say?
I was just saying, like, with this specific hospital, for example, that the majority of patients that are coming in are not coming out. AKA the majority of patients that are coming in are dying.
Yeah. Yes.
And that should never happen. That is like, you know, that right there is the alarm should be going off that something's not right here. What is it that's not right? Might be multiple things that are not right, but it's not because of COVID. You know, there are multiple factors at play here. I've also heard across the states, I'm connected with a lot of other healthcare professionals across the United States, and as well as just people who were in an emergency situation. You know, I just had someone reach out to me yesterday that said that their husband was having chest pain. His chest pain ended up being related to stress of the loss of his business due to everything being shut down. But he thought that he was having a heart attack, and they made him sit there for 2 hours while they tested him and ruled out COVID before they would even do an EKG. They didn't do any stat labs. They did not put a monitor on him, nothing. They would not touch him until they had the testing confirmation. And that's concerning. Like that's
Absolutely. No. And here's what I'll tell everybody, just FYI, if you feel like you're having any type of chest pain or heart attack, I want you to go to the fire station, and I want you to go get a real EKG, because they can actually do that there for free. That will help you determine if they need to take you in and if that's necessary or something like that, because I'm telling you, it'll keep you out of those places just as a precursor that you're not stuck there and not even getting the proper care for 2 hours, because we all know that can lead to, let's say you're having a mini, you know, and you're getting ready to hit the big one. There's meds we could be giving. There's things that we could be doing to help, you know, mediate those things. So that really ticks me off. So yeah, I don't know. That's ridiculous. At least they could be getting the EKG done. They could be given the meds on the way to the hospital if necessary. Yeah.
Like, no excuse.
Yeah, that's ridiculous. Okay, so next thing is we're being told that they're wearing the same PPE, you know, same mask, same gown all day long. And these patients are COVID positive as well as COVID rule out. And rule out just means they haven't ruled it out and they don't know if they have it and they don't know if they don't. So it's possible that they do have COVID. It's possible that they don't. But if you have the same mask and the same gown and you switch your top gloves, but let's say you're double, triple gloved or something like that, and you're only switching the outsides. I mean, we lean over patients all the time. I mean, we help them to the bathrooms. I mean, obviously probably not in ICU, but I'm just saying we touch our patients, we assess patients, we have to, it's just, it's inevitable that something gets coughed on you. I've had MRSA, you know, coughed from a trach into my eye. I have literally like, yeah, don't stand in the line of fire. You just don't do it. But I'm telling you, so it's obviously not good that you're in the same gown, same mask, just changing your outer gloves for each patient. We're normally supposed to take that off every single time we come in now. So,
and again, I want to talk about that disparity, because maybe that's not the case everywhere. So then why is that happening in some places? It's that disparity again. in the standard of care, like that wouldn't be appropriate under normal circumstances. And because we're dealing with a pandemic, because the rules go out the window, it's now acceptable to do that. And maybe places don't have enough PPE. They would be going through right? If every single patient, let's say at the hospital, was on
Yes.
those precautions, that you need PPE, full PPE for every patient, every time you go in and out of a room, we're talking about going through tons and tons and tons and tons of PPE.
Yes.
So why is that an
Definitely
issue
think
in
that's
some
the
places and
problem,
not in
is
others?
we're having enough. Yeah. And I think that it's understandable, but at the very minimum, should we keep the patient separate that could possibly not have it? I mean, you know, those
right.
nurses
So,
should
and
be
you see people
designated,
out in a
rule out only. And I mean, yes, they could potentially get infected. Like they could be infected, but then they get moved over or whatever the situation is once we find out. But I guess if your testing is 5 days, I mean, it's just it's a tough situation, but you got to try to keep them separate, or at least a different floor, or
right. That and the 300 nurses that have been deployed or sent to help and that are sitting there. Again, they could be sitting in the room as a one-to-one to where they're not going through multiple PPE.
Yes.
You gown up, you sit there all day with the patient.
Yes.
You're communicating with the other nurse, you know,
Yes.
that's in charge, or, you know, you have some sort of system, a buddy system of some
Yes.
kind.
Mm-hmm.
And I don't understand either, because I heard that the hospital ship is leaving. So it's like the hospital ship is leaving because they only saw 173, I think it was, patients. And that was it. And so I guess they're just not needed. And then you're like, well, wait a minute. Other hospitals are telling us, like, we need help. Like we're totally slammed, and we're having so many vented patients that we all know that, like, ICU, you don't usually have 5 or 6 patients like you do on the normal floor, like a med surg floor. You don't have that many patients. You're not supposed to be. I mean, ventilated patients they're a lot of work. You've got to suction, you've got to do so much. You've got to monitor monitor us way more severely than you do just the average Joe. Not saying we don't care for our patients that are just on a normal monitor, but it's just more severity. So I can't even imagine.
It just doesn't add up, right? Then that help would be leaving if it's not being utilized. So where are those decisions being made? Because that's not a bedside nurse making the decision to send the help away. You've got some of the bedside nurses saying, we're running ragged. We don't have enough of anything. We're being stretched so thin. So then why are those resources being sent away? Like, who makes that call? And on that note, I think it's important just to address, like, the culture of care and how that usually is from the top somewhere, and it trickles down, and then it trickles down to the bedside. And so sometimes when you see poor care at the bedside, that's when you look at the leadership. Like, again, why do we have better outcomes in certain areas and as opposed to others, and look at that place as leadership.
Yes. And so the PPE, there's 4 semi trucks outside of hospitals, with bodies. You're like, well, if you're so worried about contaminated bodies, let's say, or if you're worried about people dying and things like that, there's no doubt that people have been dying there. The question is, why, right? That's why we're on this thing. It's like, we get it. People have been dying. Should they have died? I mean, we don't believe every one of them should have died. We do think that there's something to be said that the treatment is, harming patients on some level. And what could we be doing better? But our inside information say that, like, there's 4 hours where they're just sitting there. Dead bodies are just sitting there, potentially like infecting others or whatever the situation is, but they're just leaving them there for hours and hours. I'm like, is that typical in a hospital setting? Do they normally sit there for that many hours?
No.
Yeah. They come and get them and take them to the morgue, right? So they're
how
sitting
about
there.
Some transparency about the dead bodies and what's going on with the trucks, because people see those trucks.
Right.
How about some transparency in explaining what's going on? Why are there 4 trucks there? Even for the staff, some of the staff does not know, and they are, again, scared. So there's this.
And is it just because we can't have funerals right now? Like, nobody really, I mean, their loved ones are dying and they want to have a proper funeral, which I can understand. And then you're like, so they're having to, like, hold on to them, but, like, the funeral homes are too stuffed, they're too busy or whatever, and they can't all hold them there. I mean, I don't know. It's just a lot of questions that we have, and things just don't always add up. So, but there's no denying that there are 4 trucks, semi trucks, at least outside of some hospitals there. And then charting. Oh goodness. I've heard charting is terrible. What have you guys heard about charting out there?
Well, we were just having this conversation previously that I've had several people reach out in medical billing and coding and saying that there's some really questionable things going on in that area, and that they are very uncomfortable with it, but they essentially can't speak about it, but they're being questioned about it, and it's just not a good situation. Sarah, you touched on
Tell
it
that
before as
something's
well.
wrong. They can
Yeah.
tell something's off,
Right.
like something's wrong.
Right.
Yeah,
So-
documentation is a big issue, and if certainly is a concerned family member, you know, loved one, that may be something that when all is said and done, you want to be able to look at, you know, request records.
Yeah, we've heard that
I
it
don't
would-
really know what else to say on that issue, because some of this is evolving, and we
Right.
would hope that records would be available. I just from doing what we do, when you have emergency situations, record keeping is not always the best to begin with. And if that becomes the norm, because this is again, the excuse that because this is a pandemic, so it just becomes normal that we keep sloppy records and poor charting, well, then what happens, you know, after the dust settles and families want answers, that documentation needs to be there. And that's going to be really telling when the dust settles, what kind of documentation comes out of this, if it's
Right.
even available.
That's definitely something that Candace Owens was saying that we need to hold them accountable for, though, for sure, is like try to get your family member or friend or whatever loved one's records if you've had somebody pass away from this. Hopefully you haven't, but try to get the full medical record, because there is, you know, ways that we can see what's been going on if it's available. Apparently we've heard that might not be the case. So try your best to get the full medical record, because it's something that we're going to need potentially in the future. You know, if this goes further, Candace Owens was saying, get as many possible records as possible in order to see what's really going on. So hopefully they'll have some documentation if that's.
And I encourage, you know, whether you work in healthcare or you have a family member that has been affected by COVID. And what I mean by that is not just someone that's been labeled as COVID that potentially has passed away from COVID, but the people that have come into the ED, for example, and have sat there for 2 hours and didn't get the proper care. I encourage those people to keep a closely documented record of what took place, document the date and time that you went in, make sure that you, or potentially try to get access to those records afterwards. There's no excuse that, you know, no matter what they tell you, that you shouldn't be able to access those records. And, you know, I encourage you to look into that. I encourage you, like I said, to document. And I encourage you, if you're a healthcare worker and you're like, yeah, there's something not right, or things are subpar, or, you know, to speak out, because people need to hear that. The sad thing is that, again, I will reiterate, if you're just tuning in, this is not an illness that should be claiming lives. It's something that some people will need additional support in the hospital, some oxygen. They might need, you know, additional treatment. However, it's not something that should be just mass taking lives. It's not this invisible killer like it's been portrayed by the media. And sadly, you know, I have my own thoughts as to why the media does what they do, because, you know, when you play into people's emotions and you play into fear and emotion drives profits. And, you know, the end goal of this is a vaccine, and vaccines make a lot of money. So, you know, I encourage more people to speak out. There are many whistleblowers, and I encourage family members to do the hard questions and the digging, you know, no matter what point you're at in this. And again, even if it's not COVID related, I didn't receive the care, or my family member did not receive the care that they should have. You know, that's a problem.
Mm-hmm. Definitely. And then the last thing about like just the information that we have received that I have is the IV drips and the poles are outside of the rooms, which tells me that they don't want to be going into the rooms all the time, right? Because if you hear a beep, you got to go into the room and it's every single time. And you're like, oh my gosh, okay, it's just so much easier to throw that pole outside of the room and to extend, the IV line. And that's really problematic because some of these patients are on 6, 8 drips or something like that. They're obviously on heavy medications. Propofol is no joke medication, right? I mean, even people not in healthcare have heard of propofol and the risks that it carries. So we're always taught to assess our patients all the time. I mean, you could literally have an IV line that popped out and it's like wetting the whole bed.
Infiltrated.
It's infiltrated. Like there's so many different things that could be happening, and we have to check and we have to make sure, we check for times 4 if they're awake, and or if they're pain levels, if they're in like neuro, or if they have just different things going on. You need to check their alert and orientation and pain response sometimes and things like that in ICU. And there's things you can't do without your hands on them, pushing, trying to check their perfusion. You've got to check their toes. You need to check all these things. And how can we possibly do that if they're just like IV poles are outside and we're just, and I know that they're saying like some nurse goes in and one stays out, but I mean, how good of quality care is that when you're like communicating about what meds at what rate? And like, I don't know, I just feel like it's another person to add into the mix to make a med error possibly too. So
I think that buddy system is a great idea, and I do believe it's being utilized in some places. I mean, I've had experience with doing that too. Especially we're going back to the PPE. If you're having to change your PPE so frequently, that's time too, that if you need to get into a room fast and you're, donning your PPE, that part of it comes in too. But I would say if you're the only nurse for that patient and you're not going in and assessing that patient and you're just managing your lines from outside of the room, is that again because of fear, because you don't want to be more exposed to that patient than you really need to be. Now the care that you're providing or not providing is based on your fear of contracting COVID-19.
And if you're going in the room and assessing, that's one thing. Like if you're going in and laying eyes on your patient and assessing them and doing all those things, and somebody else is helping grab stuff, let's say you need something from the med room or you need different things, that to me is a great buddy system because you don't have to take it off and run to the med room and then come back and everything. But it's just when the poles and everything are outside. And then I don't know. To me, it's just a little bit, if they're not laying eyes on your
concerning. If nothing else, it's concerning that you're just managing your lines from outside of the room, even if it were because more exposure to the patient means, if you could get, and they're not changing PPE, you could get the virus on you and then spread it to other patients. But then again, we go back to, well, all the patients are like mixed up anyway. So it just doesn't make sense, all of it.
Right.
Yeah. And I would be concerned that, they're not getting looked at. They're not, and who would know, right? Who would know? I mean, who's in there? Nobody, no advocates, right? So that's another back to we always need an advocate
I am very holistic minded. And part of that is the power of touch, energy, prayer, positive thoughts, whatever your belief system is. And so if nobody's in the room with that patient who, maybe put into a mechanical coma, they're still, we don't know what goes on when a patient's under like that. Is there some level of consciousness and essentially an energy field? Like there really has to be that human touch and compassion and love, and I think that that's an integral part of healing, and it's scary that that's missing again. And that's where I don't like family members not being allowed to be present. And I don't like hearing that polls are outside of rooms. I would rather hear about the buddy system or, something. They're just, I feel very strongly about the family members not being there, but at least someone needs to be there. Human contact needs to be there.
Patients get depressed too. They get down and they don't want to fight anymore because they have nobody to, even they're just listening, right? But even in comas, they're listening, they're there, like they're used to family praying over them or talking to them or singing or reading a book or the Bible or whatever it is. Like they're just used to that. Touching hands and like saying, you know, I'm here with you, or just even they can look, but they can't really move a lot or whatever, but they can still see, and they can see if their family members are there or whatever. So it helps calm them down too. Like we know as nurses, like sometimes that wife being at the bedside of that man, he's not fighting the vent as much. He's not, you know, raising his heart rate so much. He's not like, so it's really calming to them. It's really reassuring to them. So it's really sad. It's heartbreaking that family members can be, you know, dying alone. It's really heartbreaking that babies are being born without their daddies by their side or just whatever, you know. That's sad. And it's because of this fear, right? So is there anything else about what we've heard from the front lines that I'm missing that you guys can think of that I didn't touch on? So the last couple of things I was going to make just people aware of is like, just, we always in nursing use critical thinking and nursing judgment. We're always trying to like, even if it's the same symptoms, not everybody's the same genetics, not everyone's the same, you know, person and response to treatments, all kinds of things that we have to consider, right? And so, but we're always trying to do the least invasive method to the most invasive. Like least invasive is where we're moving from one side of the pendulum to the other. And most invasive in this case would look like intubation and ventilation, right? So if we're trying to lean towards least invasive, which we've already covered, but that would look like O2, you know, whether it's nasal cannula, non-rebreather mask, all these things, moving up the lines, BiPAP, CPAP, and all that. Even sometimes, like you said, double nasal cannula plus a mask. Ozone, we didn't discuss that. Does anybody want to say anything about ozone?
I just think like in the, you know, no matter what, people can benefit from vitamin C and the high dose vitamin C. And then,
okay, I skipped that one. Sorry.
No, that's okay. The vitamin C is key in this. And I really feel like across the board, whether you have it, don't have it, it's just great for your health. But then
which, by the way, you can go to an IV vitamin bar and you can go get some. It's not always high dose, but you can actually, well, in a normal sense, when businesses are open, you can actually head to an IV vitamin bar and go get IV vitamin C. So that's cool.
I'm glad you mentioned that. Chris and I actually get it done weekly, and there's several places here locally. We've gone for a long time, and you know, so that's an option. But even before ventilation, which again is mostly not helpful with this, you know, there are blood transfusions. You know, if you know about the pathophysiology behind this illness and what's taking place on a cellular level, you know, that blood transfusion is another option before ventilation. It's just really hard once you intubate and put a patient on mechanical ventilation. The longer that they're on it, the less likely they are to come off it. And again, especially if they don't have the morale and, you know, someone at the bedside or their loved ones at the bedside, it's just a recipe for disaster. So there's a lot of options. This should not be deadly. Most people should not go to the hospital. You know, if you want to take care of your health and you want to protect yourself, don't use toxic hand sanitizers, stop eating the garbage, like take care of your health, you know, go for the high dose IV vitamin C's right now. And, you know, there's a lot of things that can be done. Stop fearing the virus, stop living in fear. Fear and stress are destructive to immune function and your health. So there's a lot of things that should take place before someone that ventilation is considered, hospitalization is considered. And, you know, I just hope that this is eye-opening for some people and, you know, that it's helpful.
The other thing I was going to point to people real quick is some other articles that I found. This one is from Stat News, and it's just, it says a new analysis recommends less reliance on ventilators to treat coronavirus patients. And it goes into how we can reduce the death rate for coronavirus patients by up to 50% by implementing some of the things we're talking about. And that they actually issued a new treatment guideline. On Tuesday, I was watching the press briefing the coronavirus task force press briefing from the White House, and they had said that the NIH, which is the National Institute of Health, had a new treatment. So I was really interested, and it does include a phased approach to breathing support that would defer the use of ventilators if at all possible. So we do know that some people are going to need a ventilator, and in my opinion, there's always going to be some deaths that are going to come with a flu or any virus. And so it's not that nobody will die, but just the amount of people. And this has proven to be more like the flu than anything that we have heard. So that's why I appreciate what you're saying, Lauren. But yeah, they actually changed the guidelines, and a lot of these hospitals that we've heard of are not using these new guidelines, because as of today even, we're hearing that these guidelines are not being used, and that's concerning to me. So I just hope that they'll be able to get on board. But by Tuesday, the National Institutes of Health have a phased approach to breathing support, which would defer the use of ventilators. And so it goes on to discuss this, which I think is really important article. But it says the new analysis from an international team of physician researchers supports what we had until now been mainly two hunches, that some of the COVID-19 patients put on ventilators that didn't need to be, and that unusual features of the disease can make mechanical ventilation harmful to the lungs. So in our previous live, we had discussed PEEP flow and how ventilators sometimes were giving that puff of air, which is PEEP, positive end expiratory pressure, but basically it's that puff of air to help the alveoli to open. But some of these patients have open alveoli, so you're basically blowing the lungs. And that is something that's called barotrauma, and that is something that's actually irreversible. Once you do it, you can't take it back. So it's we could be potentially harming them, and that's what we're concerned about with giving too much PEEP flow. So what they're saying is we need to up the oxygen, lower the PEEP if they are ventilated, but we need to hold off on ventilating them until absolutely necessary, which will help them come off the ventilator. Because if a patient's on a vent, let's say we get them on nasal cannula and they're not doing well, so we get them on a non-rebreather and then they're doing a little bit better, but then they still need more support. We get them on, BiPAP or CPAP, or ultimately they do need intubation. But at this point, instead of being on the vent 2 weeks, they can maybe only be on a vent 3 days and then come right off, instead of being on it for weeks and weeks, in which we're seeing, 2 out of 3 patients, or sometimes up to 80% of the patients, are not doing well. They're dying because they've been on the ventilator. So this is one of the first coherent, comprehensive, and reasonably clear discussions of the pathophysiology of COVID-19 in the lungs that I've seen. Palliative care physician of Harvard was the first to ask if the ventilators could be harming the COVID-19 patients, especially elderly ones. And I would say that he probably, or she might not have even been the first one, but Dr. Cameron Kyle Seidel really seemed to be the one to blow the whistle on that. There is mounting evidence that lots of patients are tolerating fairly extreme low levels of oxygen in the blood, suggesting that hypoxemia should not be equated with the need for a ventilator. So just because they're hypoxemic doesn't necessarily mean they need ventilation. They need oxygenation. So here's, just some, they usually gasp for breath at this, and it's really good information. I can post the article for you guys to be able to read it if you'd like. Here's also another guy. He was, he is an intensive care doctor for 12 years. He spent 7 weeks in the Wuhan ICU, and he goes on to just say, in a quick, really concise way, he says they had trouble with getting enough oxygen in their hospitals, and they finally got a way to get what they needed. But they said they tried all of the treatments, including chloroquine. For some reason, that wasn't effective for them. Not saying it's not effective at all. I'm just saying for them, it didn't work as well. But he said what did work was oxygen. So they had a lot of success with treating their patients. And they also had a lot of success in the PPE that they were wearing. Look at how they were garbed up. I mean, this is like Ebola style, in my opinion, right? So yeah, we could be doing things a little bit better, but yeah, he discusses how oxygenation worked for them and that the other treatments maybe weren't quite as successful. Here is another just article that came out from Berlin, And it says, as the virus advances, the doctors are rethinking to rush to ventilate. And it just talks about Germany and like what they're doing, which I really appreciate because they're not having anywhere near the death count that we have had even in the US. And so what are they doing different, right? So they've been, not rushing to ventilate. It said, the 48-year-old physician, father of 2 and aspiring triathlete, so this guy was in shape, worried that an invasive ventilator would be harmful. But soon after entering the clinic, he struggled to breathe, even with an oxygen mask. He felt so sick that the ventilator seemed inevitable. So he was concerned that he was getting to that point where he was going to have to be vented. Even so, his doctors never put him on a machine that would breathe for him. A week later, he was well enough to go home. So not saying that nobody needs a vent. I'm not saying that because some patients might need one, but he felt like he was getting to that point and still was able to recover from hypoxemia just with oxygenation. So they were able to be successful. And I know that they've done a really good job. So they'd be good people to follow just kind of what their treatment methods are. This was that no variation in aerosol level. Sorry, I'll keep going. And then this next one here is an article that is from the American Society of Tropical Medicine and Hygiene. And this is respiratory support in the novel coronavirus disease patients with a focus on resource limited settings. Sorry, that doesn't really explain what we're doing here. So let me read to you this part. Supplemental oxygen is an essential step for the treatment of severe COVID-19 patients with hypoxemia and should be a primary focus in the resource limited settings where capacity for invasive ventilation is limited. So where they don't have vents, here's what we should be doing. But oxygen delivery can be increased by non-rebreathing mask and prone positioning. The presence of only hypoxemia should not generally trigger intubation because hypoxemia is often remarkably well tolerated. So they're saying that the patients can tolerate the hypoxemia fairly well. And patients with fatigue, at risk for exhaustion and things like that might require intubation and ventilation, but those would be the only ones. And they think that this is the article where they think that they can reduce the very high case fatality rate by more than 50%. And so at the end of this is the whole article. And instead of going all through that, of course, with you guys, I'll get to the very bottom, which says some pretty key things. Hang on just one second. My computer's being ridiculous. Okay, here we go. Supplemental oxygen is essential for the treatment of severe COVID-19 with hypoxemia. All hospitals coping with COVID-19 patients have to ensure the availability of supplemental oxygen, including cylinders, concentrators, centralized, all the delivery of oxygen that we can receive. Oxygen delivery can be increased by using non-rebreathing masks and prone positions. And I've seen 2 different things about that. So I'd be interested to see like how it works either way. Protection of healthcare workers with appropriate PPE is crucial. In particular, during aerosol generating procedures such as intubation, extubation, manual ventilation with a bag valve mask or suction, continuous positive airway pressure CPAP, or non-invasive ventilation with biphasic positive airway pressure, so BiPAP, provides positive and expiratory pressure, which is PEEP. But its position in the treatment of severe COVID still needs to be defined. So as far as BiPAP and CPAP, they're not quite as defined. But they said that non-rebreathers, they feel very confident about. The presence of only hypoxemia should, within certain limits, not trigger intubation because hypoxemia is often remarkably well tolerated. Patients with fatigue, at risk for exhaustion, we just went through this, sorry about that part. In these patients, lung protective ventilation is essential, including a low tidal volume. Permissive hypoxemia, so you're gonna let it be hypoxemic, and hypercapnic. So they're just explaining kind of what they're gonna look like so that you can tell, so that you can be prepared. PEEP should be carefully titrated, and it should be, from what I've seen, on the lowest setting possible. Most patients can be managed with 10 centimeters of water PEEP. Driving pressures in COVID-19 patients are remarkably low. In case driving pressure rises, potential causes like too high of the tidal volume or too high or too low PEEP should be addressed. Invasive ventilation in the prone positions should start early and last sufficiently long. And this ventilation strategy might reduce the currently high case fatality rate by more than 50%. So this, for medical professionals, I hope that you will look up this article because it is hot off the press. It literally came out 2 days ago. And I just think it's going to be really important. And we can post it, or it came out a few days ago. My apologies. But, you know, this is really recent information. So the last thing I was going to leave you guys with is this. Let me see what else I had up here. Okay, so the world ventilators are being overused on COVID-19 patients, world-renowned critical care specialist says. That is the guy we pointed to earlier, which is Luciano Gattinini, and he's from Germany. He says that only 20 to 30% of patients fully fit the severe ARDS criteria. And what he did was invent this word CARDS. So he's basically calling it COVID ARDS. And so he, sorry about that, has an article on JAMA. And so it's management of COVID-19 respiratory distress. And it's this is the one that's hot off the press from 2 days ago, April 24th. So it's brand new. It's a standard approach to ARDS versus clinical features of CARDS and the lungs. And this is basically what we've already been discussing, but he has like a time course and treatment before intubation, during ventilation, after intubation, and a weaning phase. And he's got some, ways to look and see about your patient, because there are different types. He has pointed to a type L and a type H, I believe it is, in the lungs and how they look. So anyway, just be aware of that and maybe read through this if you are on the front lines, just so you can be with the latest and greatest. So I will post these on our live, but to finish up, the last thing I was going to say is the numbers. And I know that, Lauren, you'll be excited because the numbers are not that bad, you guys. Like, we're in Texas, right? So me and Lauren at least are in Texas. And our numbers are, for Texas today, 623 deaths out of 30 million people. So 623 deaths out of 30 million is 0.002% of our population. So 0.002%. That means 99.998% of people not dying. They're okay. And that is really good news. So should we shut down the country for 99.998% of people to be fine? No, we should not. And we even have the most recent guys, those two doctors from Bakersfield. Do you know who I'm talking about, Lauren?
Where's that?
The doctors from Bakersfield. Hang on one second. Let me see if I can find it in our group, because I saw this video that was just like 2 minutes. And they talked about how we don't need to shut down the country for, they want to reopen the country, basically. And they say—
Where's Bakersfield? Is this California?
Yes.
Okay, I saw that this morning.
Yeah, there were two guys just like sitting at a table, and I meant to bring it up so that I already had it available. But anyway, there's these two doctors. I could probably find their names faster than I can even find the video. But let's see if I put in Bakersfield, if it pops up in our group, because people have shared it like crazy. Yeah, they had like an hour one, but then they also had like a 2-minute, just somebody did it on the news, and it was really quick.
That was a really good one.
Yeah, and I was like, this is perfect, because it was so fast, and it was like, and well,
didn't you text it?
I think I did give it to y'all,
because I feel like that's where I saw it.
Let me see. Okay, hold on. I won't play this because it's 15 seconds of an ad, but let me see if I can get it to pop up here. If it's the 2-minute one I'm thinking of. I found something, but either way, these doctors are like, we can't continue to shut down the country. Oh no, this is the hour one. No, this is not the one I wanted. Did I text it or did I send it to you on Messenger? Because I could pull up Messenger so
Maybe
fast.
Let's see.
Of course I did. Okay, hold on. Let's see. Bakersfield. Oh, here. I think this is it. Is this the 2-minute one? No, this is the 1 hour one too. Okay, well, it's okay. I think we're good. I don't want to take up everybody else's time, so it's all good. It was just a 2-minute little bombshell video. Anyway, I can get the guy's name. Dr. Dan Erickson of Bakersfield. And then the other guy, unless you have it and you can send it to me somehow on Messenger. Can you copy the link and send it to me on Messenger?
I'm looking to see.
Or if somebody else
No,
has
this
it?
might be it. Let me double check. Nope. Maybe you sent it to me one-on-one. I'm looking in one other batch of text messages.
Probably. We've been talking on so many different platforms, right? So I saw that and I was like, this is perfect. But it was 2 minutes and it was like, the guys were just saying, reopen the country. This is like the flu. It's not that serious. I mean, get it. Everybody's life matters. Don't misunderstand me. You know, any death is too many.
I can't find it, but we could drop it in the comments.
Yeah, we will. We'll find it and drop it in the comments. But yes, it's, you know, those guys, and they did a whole hour presentation, but it was like a news wrap up of like a 2-minute and they were just like giving you the gist, which I thought was nice.
Right.
So yeah, it was basically not to shut down the country. Now I know the country numbers are a little bit higher, of course, for New York, but even New York in 16,600 deaths as of today, out of 20 million population is 0.08% of the population. So once again, 99.92% in New York are fine, not dying, things like that. So, but what could happen if we don't reopen the country? Right? Like if we don't reopen the country, there's a lot of deaths that are going to occur because we don't reopen the country. And like you said, some people are having anxiety because they lost their jobs. They can't afford their payments. They're stuck in that, you know, house with all their kids all day and they're not used to it.
Without going on a huge tangent, there are a lot of things that people don't think about, like whether or not you believe in Alcoholics Anonymous, so AA. They have not been conducting AA meetings. Those were not considered essential for a certain amount of time. I don't know if they currently are, but alcohol was considered a necessity. So, you know, how many people turn to drinking again? How many people turn to drug use again? You know, how many people
home, you know?
Right. How many people turn to, you know, now they're turning to medications for anxiety and depression. How many people have killed themselves because they've lost their businesses? You know, there's a way that this could have been done and it did not require shutting down the country.
Yes.
We could look at Sweden. We could look at the United Kingdom, what they've done. And, you know, for people that are, you know, truly concerned or that are the more at-risk population, an exception could have been made for them to stay home and, you know, even with their own jobs or, you know, implementations could have been put into place, but it's just really a shame and things do need to go back to, or things do need to reopen as best as they can, because as we know, not everyone's going to be able to reopen after this.
Yes. And yeah, I've heard divorces on the rise because, you know, spouses are home all day together and they're fighting more than ever, or child abuse is on the rise because they're home with their kids and they're stressed out about their whatever and they're taking it out on them. Just heartbreaking things going on. So it's not just about, you know, these people. And I mean, really the thinking behind us being responsible for every other person who may or may not, let's say I have an immunodeficient child, I do. And I'm taking precautions to protect her. Like she's staying home right now for the majority, but like my husband's still been working the past 5 weeks. He's been doing a job every single day. And of course, like me at the hospital, when I come home or whatever, you know, I strip down and I get out of my stuff. I don't let my kids touch me and hug on me and everything until I'm like, you know, showered and everything. I do the same thing when he goes to work. I mean, I make him jump in the shower when he gets home and, you know, the kids just know, don't out right now, and he goes wash his hands and, you know, take a shower real quick or whatever. But like, you know, we're taking some precautions, but at the same time, we're going and, living life, but we want to make sure that when we do reopen, we don't reopen with mandatory testing, mandatory immunity certificates. I saw that Delta today has come out with saying that you can't fly. They want to make it so that you can't fly without your immunity certificate. Delta Airlines. So I guess I won't be flying on Delta.
No, they just lost a
and
customer.
we know that that's been part of their plan, like all along, right? Like that your driver's licenses and your passports and things are going to be dependent on your vaccination status. And it will be, if you're not fully vaccinated, you're not going to be able to travel or work or do things. And they've said that at the ACIP meetings, that they're going to make it not make it mandatory as much as it is force your compliance by making your driver's license, passport, and your job dependent on it. So we are fighting mandates basically right now. And, they're waiting. Many governors have said we're not reopening until we have the vaccine, until we have
those that are vaccinated then need to stay home for 6 weeks after they receive their vaccine so that they don't shed on the rest of us.
Absolutely, because even the Ebola one that's coming down the line, right? There's 271 of them in the pipeline, and that Ebola one is live, and it's absolutely coming soon, and that is 28 days. It sheds for 28 days. So I'm like, y'all can stay home and quarantine, I guess, if you really believe in that. And you're putting us at risk. But the basic tendency is like, you can always stay home. I mean, if we reopen and we're comfortable going to work and doing these things, your freedom is to always stay home. You can stay home if you're scared, and you can stay home if you're fearful. But I mean, the rest of us got to get back to work. So I hope that message rings true with a lot of different people, because we really need to put this country back to work before we're in the greatest recession of our entire existence as a country.
Absolutely.
Well, I'm glad we got to talk about all this stuff, you guys.
Thank you for hosting this. Thank you for putting this on. I'm happy to join you guys. And
thank you.
I hope
thank you.
this was helpful. I hope this was helpful for many. And again, just, this, turn off your TVs, turn off your media. This is not a deadly illness. It should not be a deadly illness. We, have an advocate, and there are a lot of things and measures that are put in place, or that should be put in place, to help prior to such extremes like ventilation. So ask the hard questions.
Of what to try and things like that to ask for, because sometimes you don't know what to ask for, right?
Right.
So hopefully that helps. And also please share this message, because there are things going on that need to be brought to light. We're trying to get this message to President Trump and others so that they know what's going on in the hospitals, because obviously he's not wandering around the hospitals right now. He doesn't really probably know everything that's going on. But when we have inside information of their and just some other information that other people need to see and hear, in case they do have loved ones in the hospital, so they can know what to ask for too. So thank you guys for coming on with me. I appreciate you so much.
Thank you.
Thanks, Sarah.
Y'all have a great night.
You too.
Bye.
Bye-bye.